Hey guys, Jugular here. So we're going to be talking about spine infections. It'll be one part of a two-part talk which include spine infections and spinal malignancy. So under the topic of spine infections, the high-yield topics for the boards include pyogenic vertebral osteomyelitis, or PVO, epidural abscesses, tuberculosis and non-pyogenic osteomyelitis, pediatric discitis, and surgical site infections. We'll touch briefly on surgical site infections, but we'll go over these topics in this order. Okay, so the term PVO encompasses the spectrum of disease of osteomyelitis in the adult patient. And so it starts at the bone and then extends into the disc. This is the technical term which we don't commonly use. It's also called spondylodiscitis. So who's at risk? Patients who are obese, malnourished, immunocompromised, diabetes is a big one, and end-stage renal disease. So lumbar spine is the most common location for PVO, which is followed by the thoracic and the cervical spine. So the term pyogenic means purulent or pus forming. So these infections are usually bacterial. Staph aureus is the most common bug. It's responsible for 50 to 65% of these cases. You can also have gram-negative infections. Most common bug is E. coli, and it's usually associated with a urinary tract infection. You also can have salmonella, which is actually uncommon in clinical practice, but commonly tested. And this usually affects patients who have sickle cell anemia or after an acute intestinal infection. So in terms of the pathogenesis of PVO, the inoculation occurs most commonly through hematogenous seeding. You can have arterial, so after a pneumonia or UTI you get bacteremia, or you can get venous through retrograde flow through the valvulus veins of Bastian's plexus. There's also direct inoculation through penetrating trauma, and you also can get contiguous spread from local infections. This is usually a retropharyngeal abscess related to the cervical spine. As I mentioned, hematogenous seeding is the most common form of inoculation. So the adult disc is avascular and it gets its nutrients through diffusion. The terminal blood vessels are small and low flow, and they're stopping at the cartilaginous end plate. So this is a great medium for infection. So these infections actually start at the bone, and that's why the term is PVO. Even though when we speak to each other, we use the term discitis and osteomyelitis, the actual infection starts in the bone, and it progresses into the avascular disc and then the adjacent end plate and vertebral body. So how do these patients present? Only 50% of them are going to be febrile. So that means that 50% of them are not. So you shouldn't exclude infection just because the stem gives you an afebrile patient. 90% of these patients are going to have back pain. And the back pain can be without activity at first, and as it progresses, the pain can be worsened with activity. And this is particularly when significant bone loss and deformity has occurred. The pain can be worse at night. There's neurological involvement in 17% of the patients. That can be radicular or myelopathic. It's increasing in frequency, but still associated with a delay in diagnosis for about 6 to 12 weeks. The white count is elevated in only 42% of patients, and it can normalize in chronic cases. CRP elevates in 4 hours of infection and peaks between 35 to 40 hours. It can be used to evaluate response to treatment and normalizes in about 10 days. ESR is also elevated and gradually peaks at 7 days. It takes about 3 weeks for it to return to baseline, and also is a very useful tool in evaluating medical response to treatment. MRI is the imaging study of choice when diagnosing PVO. However, during a test or in a real clinical scenario, you may only have plain radiographs. These do not detect osteomyelitis before 2 to 4 weeks of symptoms. The first radiographic sign is disc space narrowing, which eventually leads to disc space destruction. Here we see the lateral x-rays of a 44-year-old man with 2 weeks of neck pain radiating into bilateral periscapular areas. He has a past medical history of hypertension, hyperlipidemia, and he is a social drinker, but denies any other toxic habits. On further questioning, he does admit to injecting anabolic steroids, but says that this was in the past. On the lateral x-ray on the left, taken at initial presentation, you can see significant disc space narrowing at C5-6, which could be consistent with degenerative disc disease. The x-ray on the right was taken 2 weeks later. There has been significant progression of the disc space narrowing with collapse and kyphosis. There's also lytic lesions in both C5 and C6. Another thing that you can see on the lateral is the prevertebral swelling. Normally you should have 22 millimeters of prevertebral space at C6, and you can see on the image on the right that it's significantly more than that. CT scan is most useful for surgical planning and evaluation of bone loss. It can show structural change as early as 10 days. A technetium bone scan is indicated for a patient who could not have an MRI. It is sensitive but lacks specificity. The test becomes more sensitive and specific when combined with the gallium-67 scan. So again, MRI is the imaging of choice. The contrast enhances the sensitivity. MRI helps identify paraspinal abscesses, intracanal involvement, and also differentiate infection versus severe degenerative changes versus malignancy. PVO will have decreased intensity on T1, increased signal intensity on T2, and the areas of infection enhanced with contrast. It is helpful when you use the acronym DIE. So if you miss the infection, the patient can die. D for decreased on T1, I for increased on T2, and then E for the contrast, which enhances. Here we have the non-contrast MRI of the 44-year-old man whose x-rays we saw earlier. Along with the significant core compression, we can see on the left T1 sequence there's decreased signal intensity, and on the right T2 that there's increased signal intensity. So 30% of the patients who have PVO due to hematogenous spread have concomitant bacterial endocarditis. Echo will be the answer choice if a patient has been infected, successfully treated and reinfected, or if they develop infections in different locations. Valve replacement may be necessary to prevent reseeding. A positive blood culture or tissue biopsy is needed to guide treatment. Antibiotics should be held until this occurs. It has been shown to significantly increase the false negative rate of biopsy if obtained while on empiric antibiotics. Blood cultures are positive in 20% of the cases, and upwards of 85% of these will be the correct organism. Closed needle biopsy can be performed, usually it's CT guided. This is about 70% effective. If it's non-diagnostic, you hold antibiotics and then repeat the closed biopsy. After 2 closed non-diagnostic biopsies, an open biopsy should be performed. Open biopsy should be performed after 2 non-diagnostic closed biopsies, after unsuccessful non-surgical treatment, or if operative intervention is indicated, which include for unacceptable deformity, neurological compromise, and usually most cervical infections. These are usually operative due to instability. For the test, biopsy should be either through an anterior approach, or if posterior, use a costotransversectomy or transpedicular approach, depending on the level. The reasoning behind this is this will give you the largest sample, which increases the accuracy. Treatment goals include eradication of infection, preventing instability or deformity, relieving pain, and minimizing neurological insult. The majority of the cases are treated non-operatively with 6 weeks of antibiotics based on the sensitivity of the organism. A randomized control trial showed no difference between 6 and 12 weeks. Brace the patient for 3 months if given this option on the test, especially when there's 50% height loss of the vertebral body. A TLSO for thoracolumbar and halo vest for cervical. CRP and ESR are used to trend response to treatment. Antibiotics are the workhorse of non-operative treatment. Penetration of an antibiotic of any class into osteomyelitic bone is similar to its concentration in the blood. Penetration into the disc and inflammatory exudates is not as reliable. The disc space is negatively charged. Cephalosporins and penicillins are also negatively charged and do poorly. Vancomycin, gentamicin, topramycin, and teicoplanin do well. Linezolid is less effective against MRSA than Vanco in this setting. Operative treatment is indicated for patients with abscesses causing neurological deficits or sepsis, failed non-operative treatment, patients with severe deformity or deformity causing mass effect at cord level. Cervical PVO is a relative surgical indication. 40% of patients with cervical PVO will present with neurological deficits, with septicemia, and 80% of them will have epidural abscesses. There's also a high rate of instability associated with cervical PVO. So a lot of these patients go on to have surgery. Surgical treatment for lumbar PVO is historically done through an anterior approach with debridement, corpectomy of the involved segment or segments, with structural autograft or titanium mesh cage used to rebuild. BMP2 was found to increase fusion rates with patients who have thoracolumbar PVO. Posterior approaches are gaining popularity due to surgeon familiarity and to avoid the need of an access surgeon. There are no randomized control trials comparing anterior-posterior approaches for PVO, but significant literature showing similar results in terms of decompression and less morbidity and blood loss in the posterior-only approach. Blizzard et al. Showed that lateral surgery can be effective for spondylolisthesis or PVO. They should not give you an appropriate anterior and posterior surgical plan for an answer choice for PVO. Choose the one that best addresses the pathology. A laminectomy is normally not needed in these surgeries. We're going to move on to epidural abscesses now. These patients have more systemic disease, and early diagnosis is important due to the rapid progression that can occur. These cases are surgical emergencies. 80% of patients with epidural abscesses will have one or more of the following risk factors: diabetes mellitus, an IV drug user, end-stage renal disease, or being immunocompromised in some way. Hematogenous spread is also the most common form of inoculation. This is followed by direct. An example of a direct inoculation is spread from a septic facet joint. Most epidural abscesses are located dorsally, ventrally are more likely to be associated with the VBO, and 23% are going to be circumferential. Clinically, these patients usually present more dramatically than patients with VBO, but for the test purposes, the MRI will be the key to distinguish. The classic clinical triad include back pain, fever, and neurological deficit. Only 50% of these patients are febrile in retrospective studies. Most have site-specific pain. The white blood cell count is usually significantly elevated, and the 3 that I've taken to the OR as an attending all have had white counts greater than 20. ESR and CRP will also be elevated. They should be used to monitor treatment. MRI is the image of choice. MRI with contrast is greater than 90% sensitive for diagnosing epidural abscesses. If given the option, choose total spine MRI due to non-contiguous lesions that occur in 10% of epidural abscesses. Risk factors for these non-contiguous lesions include delayed presentation, concomitant infection, not in the spine, or ESR greater than 95. When all 3 are present, 75% of patients had skip lesions. Treatment of epidural abscesses is surgical. The mainstay is surgical decompression, debridement of any infection, and then IV antibiotics are given based on surgical cultures and or blood cultures. Laminectomy is usually the procedure of choice. A fusion is rarely indicated unless VBO is present with significant deformity or bony collapse. Emergent surgical decompression is the gold standard for epidural abscesses, but for completion's sake, I'll review the available literature on non-operative management. A patient may be considered a candidate for non-operative management, or more appropriately termed a watch and wait approach, if they cannot undergo surgery due to being too medically unstable. So they're septic or on pressors, or if they have a complete spinal cord injury, ASIA greater than 48 hours, or if they're a neurological stable patient who lack risk factors for progression. The literature shows poor results in these patients. 41% treated with antibiotics alone had worse final motor outcomes, and motor function still did improve with delayed surgery. Risk factors for failed non-operative treatment include diabetes, CRP greater than 115, and white blood cell count greater than 12.5. Surgical decompression is the answer. Okay guys, so now we'll switch gears to discuss non-pyogenic vertebral osteomyelitis. These infections produce a granulomatous response. The most common organism and most frequently tested organism is Mycobacterium tuberculosis, and this is what we'll focus on. Fungal infections can also cause this response, but usually for patients who have a CD4 count less than 50. The most common extrapulmonary location of tuberculosis is the spine. Metaphyseal portion of the vertebral body is involved. It can spread both caudally and cephalate, usually elevates the ALL, causes collapse of the vertebral body and scalloping of the body as well. You see late severe deformity associated with non-PVO versus PVO. An important radiographic finding is that the disc space is spared in non-PVO, which distinguishes it from PVO. So this is a diagram showing the most common spread of tuberculosis spondylitis. You can see the infection starting at the metaphyseal bone, spreading anteriorly. We can see here going underneath and raising up the ALL and involving multiple segments, which, if left untreated, will eventually lead to severe deformity. So the most common presenting symptom is back pain. It initially is pain without activity, but progresses to pain with activity as significant loss of structural integrity occurs. Non-PVO caused by TB presents with more systemic disease than PVO. There's usually a period of malaise, night sweats, and weight loss. Fever is rare. Neurological deficits are common, particularly paraplegia, significantly more common than in PVO. Standard infections labs should be ordered. Sputum and urine culture can be used to diagnose pulmonary and GU-TB respectively. Think about HIV testing. CD4 count usually is 50 to 200 in these patients. PPD results can be difficult to interpret due to TB vaccine in some foreign countries. So enter blood interferon gamma release assay, which is more sensitive. MRI is the imaging of choice. Well-defined, thin-walled intraspinal and paraspinal abscesses on T1-weighted fat-suppressed contrast-enhanced sequence are typically MRI findings that differentiate tuberculosis spondylitis from pyogenic spondylitis. Radiographs will show disc spaces that are spared, and chest x-rays will be positive in 2/3 of these patients. Treating non-PVO due to TB was largely a failure until the approval of chemotherapy drugs in the late 1940s into the 50s. Medical treatment is the most important part of treatment. Treatment includes all 4 agents for 2 months and then 4 to 7 months of rifampin and isoniazid. Surgical treatment should be thought of as an adjunct to chemotherapy. Surgical is indicated in patients with spinal stability, which can include severe angular deformity or progressive kyphosis. Substantial cord compression or deteriorating neurological function are also surgical indications. The anterior approach has been historically used to treat tuberculosis spondylitis, with or without posterior fixation. The posterior approach has gained popularity and has been extensively researched. It's associated with better clinical outcomes, particularly kyphosis correction and maintenance of this correction. It also has less blood loss and morbidity using an all-posterior approach. This should be your answer for non-PVO surgeries that are indicated. Okay, we're on our last topic, pediatric discitis, and then after this we'll have one slide on surgical site infections. So children have unique peridiscal vascular anatomy. The blood vessels extend directly from the cartilaginous end plate into the nucleus pulposus. Again, these vessels are small and low flow, making them a good breeding ground for infection. This causes true infection in the disc, unlike in adults. The most common bug is Staph aureus. The second most common is Kingella. Patients with pediatric discitis usually present with the inability to walk, stand, or sit. Older children may just have pinpoint back pain. MRI is still the imaging of choice even if sedation is required for the pediatric patient. Plain radiographs are normal in early disease. In the first week you see loss of lordosis. At 2 to 3 weeks you'll see disc space narrowing, and at greater than 3 weeks you will see end plate erosion. Standard infectious labs should be ordered. White blood count and CRP can be normal or high normal with just an elevated ESR. Non-operative treatment should be used for early disease in patients who do not have an abscess. In the pediatric population, empiric IV anti-staphylococcal antibiotics are given for 1 to 2 weeks, followed by 4 to 6 weeks of PO antibiotics while trending in ESR. A biopsy is obtained if no response to treatment. I have a low suspicion for TB in these patients. Surgery should be considered for pediatric disguises for chronic infections, neurological deficits, and those who do not respond to non-operative treatment. An open biopsy should be performed followed by debridement and irrigation, antibiotics, bracing, and a period of bed rest. I have one slide on surgical site infections or iatrogenic infections. They most commonly occur at the time of surgery. Higher rates and longer procedures with instrumentation. Having A1C greater than 7 is a risk factor. Using perioperative antibiotics for no more than 24 hours decrease infection rates. Adding gram-negative coverage for instrumentation has decreased infection rates. Loose hardware should be removed and well-fixed hardware can remain for the test. And vancomycin in the wound reduces infections. The answer for the test for these surgical site infections should be irrigation and debridement. Hey guys, just want to say good luck, and it was a pleasure meeting you guys and working with you. Please let me know if there are any questions or practice questions you would like me to review. You'll find my references on the next 2 slides.